Thank you, panel IUSG, for giving me the opportunity to talk on this topic of how not to miss TB, and I will say how not to overdiagnose TB as well, right, Soumya and Dr. Vishali? I'll know financial disclosures, and some of the slides, the pictures have been borrowed from Professor Vishali, and you would have heard in different presentation. But I will start the story of a dear friend of mine whom I was treating in Singapore, with history of floaters flashes, progressively worsening, had right eye redness and no pain. Saw a doctor in Chennai for right eye blurring in the vision, was told to make glasses. And this is the findings: cells and 2 plus in the other eye, some vitreous debris in both the eyes. Was diagnosed to have intermediate uveitis, a typical scenario which some of us as uveitis specialists get it, and we are always in dilemma, what do we do with that? And you do a TBT spot, you got a TBT spot positive, the patient wanted further diagnostic confirmation. TB quantiferon was also ordered by one of the treating physician who believe in doing both the test, was done. Chest x-ray also showing some densities in the right lower zone requiring further studies. Was likely diagnosed as TB related intermediate uveitis. HRCT was offered, patient was not keen, referred to TB unit for anti-TB therapy. Patient declined, and then he said the TB therapy sometimes in different centers in Singapore are given differently. So this is in one of the center where he went, he was asked to come every day to take the medicine under observation, DOTS therapy kind of thing, and which patient being a high flyer, he said, no, I can't, I will probably go to India and all. And then after that, there is a series of things which happened, but eventually the patient was diagnosed as sarcoidosis. And though these were there, and it was a mix of opinions from ophthalmologists from Singapore and India and all. So this was one of those dilemma which I believe we as uveitis specialists face every day, is whether it is sarcoid or whether it is TB. Now, how does it matter to us whether it is a sarcoid or TB? Because probably you are going to start on a treatment if you're diagnosed to him to having a TB related uveitis on antitubercular therapy, which is a commitment for 6 to 9 months at least, if not more, and you're going to put him on that. And that's where the borderline is there. So therefore, while we are going to talk on this topic of how not to miss TB, I'm also going to cover some of the aspects which will also highlight about what are the things which can probably help you differentiate from the TB versus sarcoidosis. Again, beautiful slides from Dr. Vishali again for this thing. So some of the hallmark features of granulomatous uveitis, particularly in the context of both TB as well as sarcoidosis: mutton fat granulomatous creatic precipitates, Bouchard's nodule, granulomas in the angle, Kepi's nodule, which are there and which can be suggestive of either TB or sarcoidosis. Also, there can be nodules in the angle with trabecular meshwork with tendency to form tent sepate peripheral anterior synechiae, suggestive of sarcoid, though it's been reported in some of the literature. How much, we don't know. One of the paper which we did in Moorfields also we saw this finding there. And also sarcoid can be there in vascularized granuloma if it is seen there. Intermediate uveitis, I always call it as a flip of coin. Whether coin comes up heads, probably TB, and comes up tail is sarcoid kind of thing. But jokes apart, it is again one of the very challenging thing when you get certain features of intermediate uveitis. Within that, or along with that, there can be certain lesion which can be, and we are just talking about the clinical examination. I have not touched base upon any of the lab tests, because the clinical examination is the first thing which is going to help you to go and arrive at a particular diagnosis. The next can be the chorioretinal peripheral lesions. In sarcoidosis, these are very small in size, white or whitish yellow, and present in clusters. Whereas in TB,
these are larger in size, not in clusters, and present in next to the vessels, in the vicinity of the vessels.
So this can be something which can be differentiating there. Sarcoid choroidal tubercles, small, are most common intraocular presentation in TB uveitis, seen mostly in the patients with pulmonary TB. So this has been reported in a couple of papers where they have reported about this small nodules, whether which can be unilateral or bilateral, fewer in numbers, but can be quite a lot of number as well, grayish white to yellow with indistinct borders, and mostly in the posterior pole. However, solitary granuloma with serous overlying serous retinal detachment can be suggestive of TB-related uveitis, which can be present in that particular patient with the posterior uveitis. Optic disc can be involved either in sarcoid or in patients with TB, but according to the literature, again, not much of literature is present, has been commonly reported in patients, more commonly reported in patients with sarcoid as compared to TB. But having said that, presence of optic nerve does not rule out TB-related optic neuritis or TB-related posterior uveitis. Retinal vasculitis, again, one of the very challenging thing to diagnose, whether it is a TB related or non-TB related. Again, this is a patient with 34-year-old Mendu negative hilar lymphadenopathy, only one of the eye involved, with bilateral, more common sarcoid and probably unilaterality, and that too in our observations in Moorfields in one of the data which we did, we saw more commonly left eye involved. Now, Mark Westcott and I, we've been debating about why left eye can be involved, and some of the things can be whether the heart circulation and all some of the theories which we are trying to put together, but we really do not know. It is at a very hypothesis. But one thing which has really helped us to understand TB-related retinal vasculitis is occlusive nature. So you can see really the occlusive nature which suggests towards TB-related peripheral retinal vasculitis. Now, this is a beautiful paper from Anirudh Agrawal and the team from PGI, when he was in PGI, and including our dear friend Francesco Picci sitting here, and looking into some of the lesions and describing whether this can be TB or non-TB or sarcoid. So I don't know. Francesco, which are the TB one, the top panel or the bottom panel one? Top is the TB one, correct, good. So the top larger lesions, yellowish lesions, you look like an abscess kind of thing, those are suggestive of TB. So this is where I feel AI, which we have just given the talk in the previous session, can be quite helpful. If you really see the application of AI, I will not call diabetic retinopathy, but this is where AI can probably help you differentiate one from other. The bottom panel is about the sarcoid, where there is a more flatter lesions, not so creamy yellow kind of a thing there, and this is where, and we got a confirmation from expert. So if anything goes wrong, you can reach out to Francesco. Again, presence of subretinal fluid, larger granuloma, suggestive, the larger the bottom panel, suggestive of TB, where it you see a very solitary large granuloma, subretinal fluid, suggestive of sarcoid kind of a thing there. Smaller granuloma, multiple granulomas, flattish, the choroid does not get elevated so much, suggestive of sarcoid rather than TB. So I think this is something very helpful, and one place where OCT can be really useful in picking up some of these choroidal granulomas if there is a choroiditis which is giving you some bit of a trouble. Again, some of the lesions which are suggestive of TB-like, you can see a very abnormal looking or a yellow looking lesion, and which is increasing in size, suggestive of TB. Now, this is about some of the clinical presentation. I just wanted to put in a bit of a research angle to it, and historically these two entities have been correlated quite well, and Soumya's work will really tell us how much is the immune thing which is suggestive of sarcoid, or the infective component or the immune component driving the TB kind of thing is there, and this can be quite helpful. So one of the paper which we published many years before was about the concept of, are we talking about these two entities being the spectrum of these two things, and the reason of putting it in front of the general audience is just for us to give us an understanding about what makes us think about the treatment. So this is again a hypothetical concept where you think it is a really sarcoid. I call it as a SS taken from leprosy classification. You give immunosuppressive therapy. Where you think it is sarcoid tuberculoma, immunosuppressive, and where it is TB kind of thing, it is anti-tubercular therapy. Where you think TB, you only give TB therapy, no immunosuppression. So this is the idea of if you want to bracket and segregate your classification. But again, a concept note, haven't been proven, but something which you can take. So to conclude, there is little evidence, at least based on the literature, about differentiating between these two, but some of the pictures which I have shown, and probably you must be building up some of the pictures also. So if we put together some of the pictures which will probably allow us to help us differentiate TB from other non-TB entity based on the pattern recognition, and future research can probably help us do a bit more into this thing. So with that, I would like to thank once again IUSG for giving me the opportunity to present on this TB science and all. Thank you.
Thank you, Rupesh. I think one very important message that Rupesh gave, that please do not test every patient of uveitis for TB test, and if TB tests come positive, start treatment. For example, if it looks like HLA-B27 associated uveitis, please do not order a Monteus, because if Monteus comes positive, then you will be highly confused whether to treat or not. So the phenotype is very important. If it is looking like TB, only test for TB. Don't test TB for every uveitis patients. Any questions for Rupesh? Peter, any comment?
Yeah, I think I'd absolutely agree with that. The only thing I'd add is that the COT study and the SUN criteria help you to know which of the phenotypes clinically that present where TB is a likely diagnosis and where sarcoidosis is a more likely diagnosis. So I think they're quite useful.
Thank you. Professor Sunfik, she is right now in another hall.
So I'm going to pick on you, Rupesh, now. Now, we all know these are my financial disclosure, but I'm not particularly interested in syphilis from a financial standpoint. Now, we all know that syphilis is the great masquerader, but I will start my presentation by showing how much is masquerading just with the 3 cases. So we'll place, is it syphilis or is it not? We're going to start with 2 cases. Now, this is a 36-year-old male. This is autofluorescence. You see all these hyper dots here. You can see here some attenuation of the photoreceptors and RPE bumps. This patient is 42, more or less has a quite very similar appearance of hyper autofluorescent dots all around the fundus, and even here there's RPE bumps and attenuation of the photoreceptors. So is this one syphilis or is this one syphilis? Because to me they look like mutes. I'm not going to pick on you, Rupesh, because you don't have, I should give you more data and more multimodal imaging, but this is to show you that they both look like mutes and they both look like syphilis. So the winner is actually this patient. This patient was sent actually with the diagnosis of AIM, and you see in both eyes there is this hyperautofluorescent plaques at the level of the macula and multiple dots all around. The vision is impaired. This is the appearance of the OCT that can help you, because in this particular eye you have all those RPE bumps that are quite typical of the placoid form of syphilis. So it's going to give you an idea. Then, of course, you test. This is the final follow-up of the patient, and you can see that on autofluorescence, all the small plaques and the big dots are gone, and there's a restoration of the photoreceptors and the RPE. Now, moving on to the second case. This is a patient that 28-year-old male, this FA looks like retinitis pigmentosa. Loss of photoreceptors, just preservation under the fovea. This is a bit older, 49-year-old male. Again, it looks like retinitis pigmentosa. Photoreceptors are more preserved here in the center. Now, is this syphilis or is this one syphilis? Because I promised one of the 2 is syphilis, but they both look like retinitis pigmentosa. Now, in this case, maybe the age could have told us, could have given us a couple of hints. This is the patient with syphilis. This is a patient that had cataract surgery in both eyes 6 weeks before, and he had the cataract extraction and steroids inside the eye, which are very, very bad idea in general. He did well, did a similar surgery, declined of vision. And this is not just vitritis, this is actually the steroids that were put inside the eye by the cataract surgeon. So in the fluorescein angiogram of the right eye, you can also see in the late phase this triangular shape here of hyperfluorescence that we're going to look at a bit later. And this can tell you that this could actually be an infectious disease, maybe syphilis. But in general, it's a horrible idea to put steroids inside the eye if you have no idea what's going on. So this is the OCT. The right eye, because of the steroids, had a more aggressive infection and wiped out of the photoreceptors. The left eye had a restoration of the photoreceptors. And then a final one. Is this 53-year-old man who looked like a paravenous atrophy having syphilis, or is this 44-year-old female having paravenous pigmented atrophy? Now, this one is probably having more hyper in some areas with hypocentral. This is diffusely hypo with all these weird dots.
Photoreceptors are attenuated and lost in both eyes. So is this one syphilis or is
this one syphilis. There's no way of telling, they really look very similar. And this is the winner. This is one of the weirdest cases of syphilis that I've ever seen in my life. Now, if you look at the baseline autofluorescence, you see the fuzziness of the picture, and you see on FA how much all these blood vessels are leaking, the hot disc in both eyes. And after confirming, the patient was also HIV positive, so HIV is masking and muddling the picture even more. So this is the FA post-treatment. You see the fuzziness is gone, and all the FA, the hyperfluorescence, it's more defined, and same thing for the other eye in FA. And you can see autofluorescence. Here was more fuzzy, now it's much better and clear, but these dots of hypo, they will never go away probably. So we're talking about the great pretender. I hope I showed you that syphilis can look like everything. Can look like mutes, retinitis pigmentosa, and some paracentral pigmented paravenous pigmented history of syphilis. Why was it called syphilis? Because of Syphilos, which was a pastor, and he got punished by gods, and he got these particular illnesses. All you need to know about syphilis is that, except you Indians, every European population, they called it with the name of the other country they hated. For example, the French, they call it the Italian disease. But trust me, Italians are very, very clean in these things, and we don't have syphilis in Italy. Zero syphilis in Italy. So how do you get syphilis? If you practice in a country where there's a lot of syphilis, they come out with all these weird, the patients come out with all these weird things. So I got it in a public pool. I got it by sitting on a toilet. I got it, see, now he's cleaning because he thinks there's syphilis there. He got it at the laundromat because it was so dirty. But you all know how to get syphilis, so I'm not going to go into it. Now, for general practitioner and uveitis specialists, can we use imaging to unmask syphilis? No, we cannot. So I should just go away and drop the mic here. But I will give you a couple of hints because I like to look at patterns. So a couple of, more than a couple of hints with the multimodal imaging that can point you towards the right testing to get or the right referral. The first one is
the superficial retina precipitate. This is an HIV positive male and RPR positive. You can see here all these deposits on top
of the retina and the posterior hyaloid. These are quite typical. They were described by Emmett in the beginning. You can see them very often in the areas of ground glass appearance of syphilis retinitis. Now, if you talk to Emmett, he would say that he wouldn't call them precipitates because there's not a lot precipitating, but whatever, they point towards an infection, not just syphilis, an infection. They can also be found in toxa, for example. Multifocal retinitis is something I've never seen in my life, thank goodness, because it happens when you put steroids in an eye that has syphilis inside. So there are a bunch of reports. It has this particular appearance of hyper on OCT inside the retina. But what you usually find is a retinochoroiditis. Retinochoroiditis, chororetinitis, I'm not sure where it comes from. I think it's coming from the choroid, but it doesn't really matter at the end of the day. There are two main forms, the confluent and the placoid. Now, the confluent, the most typical one, has this ground glass triangular appearance with all these dots that we saw before. The denser appearance goes into a differential with acute retinal necrosis and toxo. It's very, very yellow and less ground glass. The most common is the ground glass, which is usually triangular, like in the patient that we saw before. It's a not dense, triangular shape. It has vasculitis and hyper of the margin in FA, and you have all these superficial retinal accumulation that we saw before. Now, the second most common form of retinochoroiditis is the placoid one, where you have this plaque at the level of the macula. This is a bit beyond the macula, and it's hyper on autofluorescence. Now, this is the OCT here is pretty diagnostic because it has all these RPE bumps. So, characteristic of syphilitic placoid chororetinitis is the plaque at the level of the macula. Why at the level of the macula? Because the choroid, if it's coming from the choroid, is thicker and has a higher volume of blood at the level of the macula. On FAF, the RPE bumps are hyperautofluorescence, and here on FA there is a leakage of the whole area. See, he's liking my talk so much, he's actually telling home. He's telling people to come here. So on FA, there is a late leakage of the plaque. ICG showing hypo. Now, there's a debate about this. Probably they think that the choroid has areas of unknown perfusion that are shown in ICG, and this has been proven on OCT as well, but we're not really 100% sure. Now, what's nearly diagnostic is the OCT. In the very early stage, you have subretinal fluid that goes away by itself, and then you have your typical RPE bumps. And then if you treat the patient, restoration of the photoreceptors. Now, the final one is papillitis, neuroretinitis. Whenever you see papillitis and subretinal fluid in uveitis, you have to think of everything, and syphilis as well. Now, this brings me to the next thing, which is if you have papillitis, you need to do a CSF testing. And in the CFS, you need to check for VDRL, because RPR has a high false negative rate, and FDA-ABS is sensitive but not specific. Now, serum testing. If you look at the CDC guideline, there's two algorithms. The traditional one, which is the one we've all studied, not treponemal and then treponemal, or the reverse one, which is syphilis IgG first and then RPR. The reverse is definitely cheaper and can detect previous treatment, but can only be used in low prevalence population. So treatment of neurosyphilis, we mentioned there's a shortage of penicillin. There are other alternatives, but they need to be managed and consulted with your ID doctor as well. So I thank you for your attention.
Thanks, Francesco. A masterly overview. Are there any questions from the audience?
I want to ask you, the secondary changes, secondary syphilis, you got rashes in the bodies, then in the hand you get a placoid lesions, confluent lesions. Same thing we are seeing in the retina choroid, where you see almost in end phase there are circular lesion, confluent lesion, and dot-like lesion. Is there any skin changes related to the retina choroid?
So I'm no dermatologist, but I'm not sure what the typical lesions that you see on the hand and feet, and I'm not sure you can call them placoid. I don't think a dermatologist would call them placoid. I think it's kind of erythema or something like this, but these are full of spirochetes. So my mentor in Cleveland, Dr. Lauder, taught me never to shake patients' hands because Cleveland has so much syphilis. So even before COVID, I was like this in a room. So I'm not sure. Just to answer your question, but I don't think placoid is the right definition if you consult a dermatologist for those lesions in the hand and feet.
Yeah. Any other questions? Yeah. I think the only comment I'd make is to absolutely agree with you that syphilis can look like anything, and the Sun criteria, the diagnostic criteria for syphilis, is a positive test, not a uveitis phenotype.
Thank you very much.
The next speaker is Partho Manjamba, who's going to talk to us about viral posterior retinitis for the comprehensive ophthalmologist. Thanks, Partho.
Partho. My slides. Yeah. I'm not getting it here.
It's on the other one.
Oh, it's here. Thanks IOSG and Bishalim. Oh, it has come here.
Oh, it's come there now.
Yeah, for giving me this opportunity. So I'll be giving a comprehensive overview for the comprehensive ophthalmologist. So while when you are dealing with a case, first you have to understand that you need to recognize the clinical signs, and it can come with various clinical signs, like it can present with retinitis and all. But being an ophthalmologist, you must not miss the retinitis. For those who are not very familiar, and I'll just give them a tips that how to differentiate between choroiditis and retinitis. In retinitis, you will see that the retinal vessels are obscured, whereas in the choroiditis, you will see the vessel normally, so clearly. So now you have to remember one thing, that the retinitis is almost always infectious. Whatever the cause of infectious retinitis you think, it is always infectious, except for two conditions where it looks like retinitis but it is not retinitis. The number one is Behçet disease, where you see the retinal infiltrates, and which is associated with retinal vasculitis, and sometimes if you do a fundus fluorescence angiography, you will see the fan-like leakage, and you need to diagnose them properly, and you know the treatment is paradoxical. The second is sometimes you see that sub-RP creamy deposits like this, and these are the cases of intraocular lymphoma. Sometimes you may miss them as retinitis. So you have to do a systemic imaging. Sometimes you need to do a vitreous biopsy, and I think Professor Gupta already explained that how you should not actually if you don't know, you should not treat these cases. Better to review, send this patient to a UVA specialist or oncologist. Now, those who are familiar with only, I know many of the ophthalmologists in India, they do the direct ophthalmoscopy. So one thing you have to realize, if you are not doing indirect ophthalmoscopy, sometimes you can miss. Sometimes you can treat a viral posterior uveitis only as an anterior uveitis and can miss a dreaded conditions like this patient. So if you see here, if you don't examine the periphery, you can miss the acute retinal necrosis, which is mostly caused by the herpes virus, herpes simplex 1, 2, and varicella zoster. So usually a triad of inflammation you see in these cases. Now what are the triad? The first one is that retinitis, and it starts in periphery, a pattern that may correspond to the termini of the ganglion cells of the nerve fiber through which the virus propagates. Now the second one you see, the retinitis characteristically it shows that it's a peripheral, as I told, and they have a confluent retinitis. The edges are scalloped, and you can see the discrete margins. Now the second is the arteritis. You can see the occlusive vasculitis, mainly the arteries are involved, and as you can understand, there is a lot of retinitis and the inflammatory process is going on, and all the debris will be poured over the into the vitreous, so you see a lot of vitreitis in these patients. Now, you have to understand that this is a dreaded condition. See, it's rapidly involved the periphery, anterior retina, and if you are not treating them, the fellow eye involvement is very common in 6 weeks of initial symptoms. So you have to be very careful. So it is said that the acyclovir treatment actually reduces the other eye involvement from 64 to 24%. Now, what happens here when the retinal necrosis continues, then there will be a progressive retinal thinning and atrophy, and as a result of there may be a development of break, and also you have to understand, because there is a lot of cellular infiltration is happening into the vitreous, so there will be a vitreous membrane, and so this kind of patients will develop RD very, very frequently, and this will have both the component, both the tractional and the rhegmatogenous component. So you have to be very careful when you are handling a patient of acute retinal necrosis. You have to tell them in details that these are the patients are prone to develop the retinal detachment and other complication. Another posterior pole viral retinitis is that progressive outer retinal necrosis. I'm not going to tell you the abbreviated name. So it is characterized by the absence of retinal vasculitis. There will be minimal or very less inflammation in the vitreous, and it progresses entirely, but it starts reverse way of ARN. It starts from the posterior pole and involves the periphery. Now, when you are dealing with the posterior viral uveitis, you have to identify the vasocentric lesions. That if the lesions are vasocentric, then you have to suspect that it can be cytomegalovirus retinitis, which can be bilateral in 30% patients. And these are notoriously white eye uveitis. Sometimes there will be no congestions and nil or minimal vitreitis. And it can affect all the areas. It can affect the posterior pole, periphery, or both simultaneously. Now, if you see the broad differentiation between the HSV VZV infection and the CMV, the first one involves the immunocompetent patient, and CMV is most commonly seen in immunocompromised, though we can see the involvement in immunocompetent patients as well. But you have to understand that the HSV and VZV enters the eye through the neurons, whereas the CMV, the primary mode is it's hematogenous. Now the second one is very important. The HSV and visit B replicates very fast and it will finish off the retina within a period of time if you are not starting antiviral. Whereas compared to that, the CMV that replicates very slowly. It has been seen that every 18 hours is their replication period. So it has a relatively slower progressions. Now there are broadly 3 varieties you can be seen, and most of us, we are familiar with pizza pie retinopathy. So you know that how to diagnose the fulminant. Let me tell you about the indolent variety. Indolent variety is granular, often can be seen in periphery, and you miss that pizza pie-like appearance, that you may not see hemorrhage in these cases, so don't miss them. Think that always remember that the granular variety of CMV is little different than the conventional variety. Now frosted branch angiitis can be seen in various other conditions. One of them is CMV, and it requires detailed investigations and imaging. So now when you are dealing with the immunosuppression, you have to, when you are dealing with a CMV retinitis, you have to pay attention to the history of immunosuppression. Now this immunosuppression can be disease or therapeutic. You have to rule out HIV in all patients. And one more important thing you have to realize in this era of anti-VEGF and diabetic retinopathy treatment, that local immunosuppression. So if you are not getting any proper history, always ask the patients whether there is any previous history of any intravitreal steroid injections or not. So this is immunosuppression is very important. I will show you a case of 22-year-old female who presented with a history of dengue fever, and she developed a biopsy, skin lesions. You can see the biopsy revealed pyoderma gangrenosum, which was treated with cyclosporine. And you can see that based on the photograph and all, we realized that it's a case of CMV retinitis. We treated the patient with intravitreal ganciclovir, and the retinitis resolved completely. HIV was negative in a 22-year-old female. I was desperate to find out that why it happened, so I sent the patient to an infectious disease specialist. Now the infectious disease specialist called me and told me that, see, I can't find anything, so let's do a PET scan. So I just ordered a PET scan and sent the patient back, and later we realized that the PET scan showed hypermetabolic enlarged supradiabetic lymph nodes, and CT guided biopsy found that it was a case of diffuse large B-cell lymphoma. So sometimes this CMV retinitis can be a presentation of this kind of manifestation also, so which you keep in mind. Now this is very important in our country, that do not rely on serology as a laboratory diagnosis for the herpes viruses. Torch titer is not going to solve your problem. Many times I see that some retinitis, some anterior uveitis also, people will rely entirely on the torch titer and try to treat them. Look at these 2 studies that 92% of the humans shed HSV1 DNA in their tears. The other study showed that the 93% of the human autopsy revealed that there was a HSV1 DNA in their trigeminal ganglion on autopsy. So you have to understand that the polymerase chain reaction remains the mainstay of diagnosis, and only 2 serological tests you do in cases of herpetic uveitis is that you rule out syphilis and HIV. So coming to the treatment of the herpetic viral retinitis, that primary aim, as I discussed, arrests the progression of the retinitis and prevents the other eye involvement. So it is important to differentiate HSV, VZV and CMV. So you need to do a PCR, because CMV lacks the thymidine kinase. So if you are treating a CMV with antiviral like acyclovir, it's not going to respond. So this is the basic thing you have to understand. The second thing is that the valacyclovir has higher viability. So is the valganciclovir, which has higher viability than the ganciclovir. So these are the treatment, and ideally it is the combination of the systemic and intravitreal antiviral which is preferred. So you need to add the ganciclovir, and sometimes if it is not responding, then you can actually go ahead with the foscarnet. Now, do remember these 3 basic points when you are treating a case of herpetic retinitis. The number 1, all these drugs are virustatic and not virucidal. That means the reactivation of the herpes infection will start again if you stop the antiviral. The second one, these antivirals has limited effect on the latent herpes virus. So the moment you stop the antiviral, there can be a reactivation of antiviral. So this is a very important point you should take home. The second is it is not the antiviral. Don't treat posterior herpetic uveitis only with intravitreal, because intravitreal therapy alone can have a higher risk of the other eye involvement. So you have to give the systemic antiviral to prevent the other eye involvement. Now coming to one point here, that optic nerve involvement sometimes can can be seen in these viruses. So that's why the corticosteroid in systemic doses sometimes may help. But please be sure that you are not injecting any intravitreal steroid in this patient. It will be disaster, so don't inject any intravitreal steroid in these cases. Now there is another important point, that history of fever we see, and there is a viral retinitis. So overall you see there is an umbrella signs like posterior viral retinitis following fever. I'll just try to highlight these three entities. One is the dengue. The dengue will have a multifocal retinitis. The hemorrhagic retinopathy can be seen, and they have they can have a macular involvement. The next one is the chikungunya. It is multifocal, and phenotypically it mimics herpetic retinitis. Sometimes it is very difficult to differentiate from herpetic retinitis. The third is West Nile. I thank Mr. Kairala for this photograph. So West Nile virus, these are also multifocal, but you can see this linear pattern of the retinitis, which actually related to the course of the retinal nerve fibers. Now most important is this herpes. After fever there can be reactivation of the herpes viruses as well. Now if you see that what are the single most factor that can cause the reactivation of the herpes viruses in the ganglion, is that rise in the cyclic AMP level. Now this cyclic AMP level can be raised even after fever, even after emotional stress, this cyclic AMP can go high. So reactivation of the herpetic viruses can occur even after that also, and after fever also. Look at this picture. This picture often looks like a chikungunya retinitis or some other retinitis. The patients had a history of fever, and finally the PCR showed it was a case of VZV, and we treated with oral steroid and acyclovir, and it dramatically responded. Now when we talk about fever and retinitis, this is a girl referred from Bangladesh, had a diagnosis of post-viral retinitis with rash, myalgia, and you can see the joint pain. And this girl, the presented picture like this, you can see here there was an area of retinal whitening. You can see that marked venous tortuosity and hyperemic disc. So only positive was the girl informed us about a history of photosensitivity, and the subsequent investigation showed that she was positive for ANA, and subsequently we found that it was a case of systemic lupus erythematosus. So basically we were dealing with a case of Puschner Flacken secondary to SLE, and sometimes the SLE patient, they can develop fever, they can develop myalgia, so sometimes it can be mistaken as a viral uveitis. I'll just take 1 minute more now. So sometimes you have to understand that atypical lesions like peripheral lesions are not ARN. It can be snowbanking, it can be serpiginous choroiditis, and sometimes can be ocular toxoplasmosis also. So toxoplasmosis is a major differential diagnosis because it can have a virus, it can have a high IOP, it can have an anterior chamber inflammation and significant reaction of the vitreous. OCT is a valuable marker, as is a paper by Alexandro and Anirudh, and they showed that you can see these hyperreflective oval deposits in the inner surface of the retinal. So you do a OCT in suspicious cases, which will help you. I'll just conclude with this, that not all viral retinitis can be treated with injectable ganciclovir. Like this 29-year-old male presented with sudden diminution of vision and history of fever, and over a WhatsApp chat, I just saw the photo and I just asked the ophthalmologist that let's send the patient here. So when the patient came here is a young male, and I sent the patient to neurologist, and I was asking that can you do a CSF tap? The neurologist was telling EEG is normal, there is no CNS finding, why you want me to do that? So finally that anti-measles antibody from the CSF was both high in serum and CSF. So this was a case of basically a measles retinopathy. So sometimes this as you know that this kind of disease is near fatal disease. It presents with focal necrotizing retinitis, and even if you treat them with interferon, it is not going to prevent the death. So it is a fatal conditions, and you must actually diagnose them early. So I'll just conclude with that for ruling out the posterior viral uveitis, rule out the mimickers of the retinitis, examine and identify the clinical phenotype of the viral retinitis. Torch titer has a limited role, PCR has a better sensitivity. Immunosuppression, systemic or therapeutic need to be ruled out in cases with CMV retinitis. Optic nerve involvement is an important cause of visual loss in viral uveitis. Pay attention to that. Intravitreal and systemic antiviral is the mainstay of treatment in herpetic posterior uveitis, and testing HIV and syphilis is a must in all cases of posterior uveitis. Intravitreal steroids should not be used in viral posterior uveitis. Subaqueous sclerosing panencephalitis or
and the medications were then tapered off. And then he came back again, and you can see that he's got this KP here. If you look at the distribution, you know, it's more than what we would expect for any kind of PI-related or angle closure-related kind of inflammation. They don't get keratic precipitates, right? So after a while, he seems to quieten down. His pressure is good. But you can see that these KP, they are pigmented. Okay, that's a bit unusual, right? Even if you hit the iris, you shouldn't get all these clumpish, pigmented KP. You may get some pigment liberation, especially if you have done iridoplasty. So 2 months after the initial presentation, he presented with dendritiform corneal lesions, some corneal edema, keratic precipitates, anterior chamber cells were present. So he was treated again by the general ophthalmologist with acyclovir 5 times a day, and it resolved, it responded well. So they thought, in the case notes was written, query hepatic, all right, HSV kind of keratitis. So the following month, he came back. This time, the pressure had gone up again. It was 30. He had cells, and he had keratic precipitates. So at this time, he was referred to the uveitis clinic. That's 6 months after his initial presentation. And of course, what we typically would do is paracentesis of the AC, aqueous, sent it for PCR analysis, and this turned out positive for VZV, okay, varicella zoster, and it was negative for the other viruses. So we treated him orally, and this was then reduced, and we gave him only like 1 month of treatment, and he subsequently resolved. He never had vesicular eruptions. So no one would be able to really diagnose this case if not for PCR analysis of the aqueous. So is this the end of the story? Well, if you have only treated VZV after 6 months of the disease from presentation time, you would expect complications, which 3 months later, now he comes with bilateral fine KPs and cells. Then you begin to wonder, bilateral viral uveitis, a little unusual. Okay, so 1 year later, the same right eye
that initially presented developed neuropathic keratopathy. He had all the punctate epithelial erosions you can see here on the cornea. And then he has bilateral high pressures in both eyes, and he has developed fine feathery KPs, like what you see here. And now the left eye, the right eye, we tapped again because we were not certain whether it was something else
or just a recurrence of the VZV. So we tapped him, and he was negative in the right eye for viruses, but the left eye was positive for CMV. Okay, we never expected it to be CMV because this guy's got VZV in his right eye, and he's actually healthy with no underlying immunocompromise. So we treated this patient with Vergon gel, which is ganciclovir gel. So this patient actually improved for some time, but if you look at what happened thereafter over the next 8 years, all right? So he developed cataract, he had glaucoma, the right eye that needed glaucoma surgery. The left eye, he developed cataract, which is not unexpected for his age, but he needed a trap MMC. And then the right eye, which was neuropathic, had a paracentral melt with secondary infectious keratitis, and then he had to undergo a DELC. The left eye had penetrating keratoplasty because it was delayed diagnosis because of CMV. He had endothelial failure, and then he had vascularized grafts, so twice failed, but he had no recurrence of CMV thereafter when he was appropriately treated. And then at the last that we saw him, he had 6/12 vision. That was the eye that had the VZV, but the left eye was light perception because the cornea was opaque. And then he passed away 2 years after that. So you can see there's a downhill progress when we miss the diagnosis. Okay, so suspect viral etiology in hypertensive anterior uveitis. VZV anterior uveitis can present in the absence of vesicles, and so you really need PCR for analysis. Both eyes can harbor different viruses. You need PCR really to make the diagnosis, to give the appropriate treatment. Eyes with viral anterior uveitis tend to develop relapse, okay? Glaucoma develops over the long term, and so does cataract. CMV eyes undergoing corneal transplantation have a very guided prognosis because you give them topical steroids and then they will have further relapse and loss of endothelial cells and failure. So missed or delayed diagnosis results in really serious loss of vision for our patients. So how then not to miss a viral anterior uveitis? So when do we suspect a patient to have a viral etiology? So usually these patients present with one eye involvement. They have raised pressure at the time of presentation. Iris atrophy may be present, pigmented, small, medium-sized, or others may have stellate and diffuse KPs. The presence of corneal involvement, either acute or just in the presence of scars, and the early development of cataract in some types of viral uveitis. So the pressure is raised. Are there causes? So if it is low, we think of B27-associated anterior uveitis or retinal detachment, right? But if it's high, we think of an infectious cause. So you can see some viruses here, herpes simplex virus, varicella zoster virus, Fuchs uveitis syndrome, which is associated with rubella, Posner-Schwarzman syndrome, which sometimes on repeated TET may become positive for CMV, toxoplasmosis, infection, syphilis, sarcoidosis can do this. Of course, lens-induced glaucoma can do this too. The other thing is to look at the iris, okay? Do not just dilate. Look at the iris before you dilate. Look for the shape, all right? You may see iridopecia like in this patient here. There may be atrophy or stroma or pigment epithelial layer. Sorry, is someone, okay. And the stromal involvement may be patchy or may be diffuse, so you can see some examples here. If you have a segmental area of involvement, it's typically HSV or VZV, and you can see in this case of recurrence, without appropriate prophylaxis, this patient had severe transformation defects and he suffered from severe glare because this just tended to recur and destroy more of his iris that involved not just the stroma but also the pigment epithelial layer, giving the transformation defect. So if you are dealing with something like CMV, all right, whether it's a chronic CMV or the acute recurrent, which we call Posner-Schwarzman syndrome, they tend to get more stromal involvement and just patchy or diffuse atrophy. So this CMV involvement can look just like a rubella, eye with rubella virus, okay? And VZV tends to be far more severe than HSV in terms of iris atrophy, and they can get even a fixed dilated pupil that transminates after a single episode of severe infection. So CMV and rubella both have very low flare and they do not develop posterior synechiae despite chronicity. So that's a very nice clue for you if they have recurrent inflammation, chronic inflammation, and yet the iris does not get stuck down. And of course, if you do gonioscopy, you may see anthracene positive in both these viruses. How about the KPs? Can you tell whether these KPs are infectious or not? And very nice work has been done initially from James Rosenbaum's group and subsequently other authors, including Padma Malini. And they can have shown that infectious and non-infectious KP look different on confocal microscopy, which gives you a very highly magnified view of the KP. And typically, infectious KP look either dendritiform or infiltrating as compared to non-infectious, which look more smooth and globular, and others may be cruciform or stipple. So is there a clinical correlation with this? When we look at the patient clinically, you can see this is dendritiform, and this patient was CMV positive. This was globular, and this was biopsy-proven sarcoidosis. And this, interestingly, infiltrating, you can see, in fact, they've got little streaks there coming out from the KP, and this was vitreoretinal lymphoma. So how about the pattern of the distribution of the keratic prep state? We've been observing that KP that go above the horizontal meridian point more to an infectious than an immune cause. So for example, HSV, VZV, CMV, which is diffuse, rubella, which is diffuse. So, you know, when we look at Fuchs uveitis, what are the associations with these diffuse dendritiform or infiltrating KPs? They are mostly infectious, right? So rubella has been associated with Fuchs uveitis syndrome. CMV, chikungunya virus, HSV has been reported as well, Ebola virus. So these are mainly infections, as you can see here, except for sarcoidosis. And maybe sarcoidosis may be infectious actually in the origin, in the trigger. So the KP distribution, you can see others here like VZV, they go above the horizontal meridian. This is HSV1, you can see very diffuse involvement, and this is syphilis, it goes right up here. Okay, so look very carefully at the distribution, it may indicate a possible infectious etiology. So you just do note that, when we're talking about the distribution, we're talking about when the patient first presents to your clinic. Of course, the patient is already treated before his patient sent to you, you may actually not see these signs. So this patient here had actually very diffuse type of infiltrative KPs. So when this patient was treated, you can see this was CMV. The KPs start to change and evolve. All right, they become a bit more granulomatous. And at the end, very interestingly, the top ones were granulomatous and the below was still rather dendritiform. So we're talking about when the patient first presents to you, if they are diffuse, they're dendritiform, and so on, these would tell about the possible characteristics and etiology of the underlying trigger. The color is very useful. So pigmented KP, they may help to suggest a viral infection. So my resident asked me today, this week, and she said, I thought pigmented KPs are all KPs. So when we look at these pigmented KPs, they are not small and crenated KPs. All right, they're actually fresh KP that are pigmented that would suggest a viral etiology as compared to these other etiologies where typically they do not get pigmented. There are some characteristics of the KP that may help you to make a diagnosis. This is CMV with coin-like lesions. This is nodular endothelial lesions that you can even image on ASOCT. And very useful if you're suspecting this could be CMV or perhaps rubella. When you see a Fuchs uveitis syndrome, you do the endothelial cell count, and when you have a significantly reduced endothelial cell count, suspect CMV. All right? If you find scars, all right, you would think more of infectious cause here, right? Think before you even dilate the patient and check the pressure, please check the corneal sensation because hepatic viruses do cause a decrease in corneal sensation. So of course, non-granulomatous uveitis can also cause corneal lesions, but the keratitis tends to be more peripheral. And you can see some of these here as compared to the viral keratitis that you may see scars or active lesions. The characteristics of rubella uveitis are quite different from the herpes viruses, tend to be in younger patients who present with a white eye, stellate or diffusely distributed non-pigmented KP. You may have catechromia even at presentation like this patient of mine. Copy nodules may be present, posterior subcapsular cataract may be present in 50% even at presentation at a young age. Vitritis is almost always present. If you look for it, generally they do not have macular edema, even in spite of vitritis. And if you look carefully, some of these patients may even have chororetinal scars. So it's important to confirm the diagnosis because it would impact on your treatment. So aqueous tap is usually done when the eye is active, especially when you have a high pressure, and this gives you a better chance of getting a positive result. So in conclusion, a high index of suspicion is necessary when the patient presents with a high pressure, the KPs that go above the horizontal meridian, pigmented KPs, presence of iris atrophy, corneal manifestations, including a reduced endothelial cell count, and always remember to do a dilated fundus examination to rule out posterior segment involvement. Thank you very much.
Any questions for Professor Chi?
Can I ask one question? First case is neuropathic changes. Now, if in vivo confocal microscopy, plasmamyelitis paper, and you see the nerve pattern changes with the KPs, different KPs, with all these markers.
Okay, so you brought a very good point because people are now looking at the number of nerve fibers and all that, but I don't think that's really anything that's been published from her group on this. But I think Rohit Shetty has been publishing on corneal nerves, and it will be interesting to look at this. Thank you.
Okay, thanks, Subi. So our final speaker, but by no means least, is Professor Vishali Gupta from Chandigarh, and Vishali is going to, I think, tie this all together for us with her talk.
Thank you, Peter. So this is the last talk of the session, and the topic I have been given me is that looks like uveitis, but it is not. So Partho already explained to you very beautifully that uveitis can produce either retinitis, which is very typical, or choroiditis, which again is very typical. But if you are seeing some deposits in the subretinal space, which is neither retinitis nor choroiditis, it is unlikely to be uveitis. And I have been showing this patient for years now because this patient was treated for TB with steroids, anti-TB drugs. This is not uveitis. This is CSR with fibrin deposition. And if you give steroid, it worsens it a lot. And the fluorescein angiography is very helpful. The choroiditis lesions are hypo to hyper. CSR will be hyper with more expanding in the late phase. Another such example, the laser burns, and you can see the child was playing with the laser toy shining into his eye, and this was confused with uveitis. There is no way a choroiditis is going to present like a linear lesion like this. So it's not uveitis, even though this patient did have IgG4 disease, but this problem is not related to uveitis. Dystrophies, I think I have been emphasizing a lot in this meeting, is about dystrophies because many of the time, for example, this patient was diagnosed as retinal vasculitis, and that is how the patient came. He was receiving treatment for retinal vasculitis, and the diagnosis was retinal vasculitis with retinitis pigmentosa. Now, if you see here, there are some bony spicules and there is periarteriolar sparing, which is more characteristic as you see on the fluorescein and FAF. So you can see this typical pattern. This is not the pattern of leakage of uveitis. This is something masquerading, and this patient actually had CRB1 mutation associated Leber's congenital amaurosis. So there is no need to get confused and starting steroids. Similarly, this patient. This is the patient which was diagnosed as serpiginous choroiditis, but serpiginous choroiditis does not present so symmetrical, so flat, no leading edge, no yellow edge. It's just a flat lesion which is bilaterally symmetrical, and that's how you see it. This is actually helicoid peripapillary chorioretinal degeneration and not serpiginous choroiditis. Drug toxicities, this is what I wanted to highlight. There are two kinds of things. One is the drugs induce uveitis. The second is the drugs cause toxicities which can be confused with uveitis. Now, this is a 68-year-old lady. She was diagnosed as intermediate uveitis in Canada and was being managed with immunosuppression. Now, when you look at it, there was nothing much happening in the eye except the presence of this symmetrical, bilateral kind of a pocket of fluid. Now, this is not what you expect in cystoid macular edema due to intermediate uveitis. This is unusual. So I would put my money either on dystrophy, and if the dystrophy has been ruled out, these days we ask more and more about the history of the drugs. So this patient did we did fluorescein, ICG was normal, and fluorescein showed, something was happening there. She was actually on sertraline therapy, and when we look the literature, sertraline is known to cause some kind of maculopathy. So for her, we did electrophysiology. It did show changes. We just stopped the drug, and this is post 2 months after stopping the drug, the edema or whatever it was responded. So this is published in AGO. Another case, this patient is a young child who had X-linked chronic granulomatous disease. Now, this is the disease which is caused by CYBB gene mutation and produces recurrent abscesses in the liver. So he required multiple admission, IV antibiotics, pigtail catheter drainage, and was on oral itraconazole 200 milligrams Septron for the past 6 years for his systemic disease. He also received clox and linezolid 7 months back. So he came to us as a case of fungal endogenous endophthalmitis, knowing his history of the disease and predisposition to fungal infections. So what we did, we ran the OCT through this, and this did show there was a lesion in the in the retina, but what was interesting was these microcystic spaces in the internal limiting membrane. That's not a feature of endogenous endophthalmitis. The literature search indicated that linezolide drug, which he was on since the last 7 months, is known to produce these changes in the inner retina and internal limiting membrane microcyst. So we discussed it over. He was already on itraconazole, even if it was fungal, so we did nothing except stop linezolid. And you can see the top is before stopping when he presented. The bottom is after stopping linezolid 2 months later. So every case, the last part is that many a times you see serous detachment and you think it is VKH, but every case of serous detachment is not VKH, or CSR for that matter. For example, this lady had a mass-like lesion and there was fluid. You do the fluorescein angiography, and this is very atypical. It's a mass-like lesion. So whenever in doubt, do an ultrasound. Ultrasound in VKH is very different. It is just diffuse thickening of the choroid, which you can demonstrate both on V-scan as well as on OCT, EDI OCT or swept source OCT. But this lady had a kind of a mass-like lesion, a flat mass, which had broad-based and had a height. There was associated retinal detachment. So these are the cases where you suspect choroidal metastasis. So there is no point wasting time on looking at anything. Just get a good history. She did fortunately give some history which could be pointing towards this. We just got the PET scan, and it was actually poorly differentiated carcinoma in the lung for a 40-year-old lady who had no history of smoking or whatsoever. But it is just based on your clinical examination in the eye. So the conclusion is, if it does not look like uveitis, it may not be uveitis. So don't force the patient into a diagnosis of uveitis by pushing steroids and buying time. It may be you are seeing something which you are not aware of, which is not so common, or which is just a different manifestation. So it may be a good idea to review the literature. For example, that linolide toxicity and all, I wasn't aware. So when you go to the literature, you will invariably find that you are not the first one seeing these atypical cases. Somebody has already reported it before you. So that's all. Everything is not uveitis, Peter. Thank you.
Terrific. So I guess, Vishali, it comes back, doesn't it, to the clinical assessment, history, examination, and then going back to the history.
Yes. Yeah. Any questions from the House? Any questions, Dipankar?
Sometimes cause optic nerve changes also.
Right. It mostly causes, yes.
So seeing the optic nerve also along in this,
And
doing the what you call other electrophysiological
right.
RNFL or CT.
And also very important, many patients on immune therapy these days, checkpoint inhibitors, they develop VKH-like disease. So if your patient is on checkpoint inhibitor as a part of chemotherapy, that's not likely to be VKH. That is the disease induced by checkpoint inhibitors. We were not seeing so much of drug toxicities, honestly, but now we have started seeing quite a few of them. So it's important not to mistake them for uveitis.
Yeah. Okay. Well, it's just on 4 o'clock.
Yes,
Charlie?
it's just 4, and on behalf of International Uveitis Study Group, thank you very much for attending our session. Thank you.
Thanks, Michelle. That's good.